Thank you
Well,
for
welcome.
joining the ASPN webinar on challenges of race, gender, and bias in pain medicine. We are going to give everybody 2 minutes to log on, and then our moderators will begin the program at 6:02 Pacific, 9:02 Eastern. Thank you for joining the ASPN webinar on challenges of race, gender, and bias in pain medicine. We are going to start in 1 minute to let everybody log on, and then our moderators will begin the program. Thank you for joining the ASPN webinar on challenges of race, gender, and bias in pain medicine. We will now begin the program.
Well, thank you, Michelle. And thanks everyone for joining us tonight. I'm Tim Geer from West Virginia. ASPN was originally created to bring out collegiality amongst our colleagues in pain to help encourage each other to be successful. And while that's been our goal all along, we really feel this point in history is a very important time to come together and discuss the issues of race, bias, inclusion, diversity. And so while we discussed this issue, many people said, it's a very risky thing to talk about. Maybe we shouldn't bring this up. But our team felt that it was important for all those in our field to address this issue in a way that we could actually bring it to the forefront, not just to make a discussion. Someone's not muted, actually. Sorry about that. Not to just have a discussion, but to think of some solutions. So our goal tonight is to bring our thoughts to the forefront as we go through some very sensitive topics, to get each other's thoughts out there, and then take those thoughts and let that be a springboard for healing, for togetherness, and for love. That's our main goals. So that's my introductory comments. I'm going to go to my colleagues now for their thoughts. Krishna.
Yep, thanks, Tim. First of all, I think, we're kind of witnessing a really important time in history where a lot of the challenges that we've dealt with as terms of race, religion, bias, all of these things that have kind of culminated in a time where we have this unique place in history to try to do something important. And I think that part of that is, as grand as it is, I think one of the key takeaways that a lot of us really realize is that part of really making effective change comes with listening. And today you're going to hear a lot of our colleagues who've taken time out of their personal time to share something in their own experience in life that has brought them to some type of personal solution and or suggestions on how we as a society can listen to your needs and try to come up with something that's practical. And what I want to really emphasize is it takes a tremendous amount of courage for each of these faculty members to put themselves out there to talk about something that is very personal and impactful in their life. And it's us coming together. I think this is a great moment for us as a medicine, as a field, really to address these sensitive topics. And I have to really commend, I think, when Tim had this idea originally and the rest of the folks that have kind of come together, it's you have to really pride them and for taking that opportunity to take that. So really excited to be here. I know we've done a lot of webinars together, Tim, so this one's really special. So I'll turn it over to Natalie to give her comments before we start.
Thank you both for that amazing introduction. I agree with everything you both said. And to introduce myself, I'm Natalie Strand. I'm speaking from Arizona tonight. And one thing I'd like to add is that we're going to be talking a lot about bias that has been experienced, and I think that has to be placed next to bias that we all may have and that we probably all do have. I think it's important to create kind of a safe space for us to learn. To have bias is to be human. It's to be a person and be shaped by your own personal experiences and the environment in which you've come up. And so if we can normalize bias, I think that makes it easier for people to take a look at it without so much shame, without so much defensiveness, to actually acknowledge what our personal biases may be, and that will create a safe space to actually allow the work to be done. You know, bias is a healthcare issue. It's important for personal growth. It affects the treatment decisions with our patients. It affects what papers are published. It affects hiring. It affects academic promotion. So I'm just so happy to be a part of this important work. And I do believe that the conversation starts tonight. And I know that there will be action items that we all put forth to follow this very important discussion.
All right. So I think we can start with, so the agenda is going to be, we're going to cover 4 different key panels. We're going to start with religion, we're going to talk about race, and then gender and sexual orientation. And each of the moderators are going to kind of either piggyback on 1 or 2 of the different panels. The plan is to kind of be on time. We're going to give about 15 minutes per panel, and then we're going to try to ask some questions, and then Tim, myself, and Natalie are going to wrap up with some final thoughts. So I think we're going to let Tim introduce this first panel, and I'm going to pass it over to him at this point.
Well, thank you, Christian. And so I'll have the other panelists on this first panel turn on their video cams and join me. And certainly I'm going to let each of them introduce themselves as we go. So, but I think, you know, when we thought about this, we thought about all the different things people are biased about. So as you may recall, when you're a child, they say never talk about politics or religion at your dinner table. We're going to do exactly that tonight. We're going to talk about politics and religion and gender and sexual orientation, and all the things that are very important that we have the discussion on. I grew up in a small town in West Virginia. And in that small town, we were all coal miners' children, and we were poor, and we lived together, and we're the same race, and we had different religions, and we got along. So I know it can happen. I've seen it, but I've also seen racism, and I've seen bias against people for their religion. So we have a great panel tonight, and I think I'll start with Jackie, and maybe some of your thoughts, some experiences with your religion, and how it may have affected both your personal life and maybe your patient care, and then we'll go down with the entire panel.
Sure. Thanks, Tim. I'm Jackie Weisbein, and if my last name didn't give it away, I am Jewish. I grew up on the East Coast in Florida and New York and Philadelphia, so always around other people who shared that same background. And then I moved to a small town in Napa, California. And I didn't think it was going to be such a small town until I moved here. And on one of my first days at work, one of the people in my offices actually said that I was the first Jewish person that they met. And then they asked me if I had horns, which I came to find out was something that was a belief that people had about Jews, that they had horns and a lot of other different things, which was untrue. But obviously, it was interesting to meet someone who, in 2012, that still thought that that was a viable thing. So that kind of helped me realize that I was now living far away from where I grew up, and not in Kansas anymore. But it really helped me understand that I needed to be mindful of the fact that we all come with implicit biases about the places that we live and work and how we interact with people.
So I think that's a good negative experience and an eye-opening experience. I'm going to go back for a moment to Navdeep, because Navdeep, when I thought about this panel, religion, you're the first person that made me think of this panel. And I told you a story about 9/11. After 9/11, I have a friend who's Indian, and he and I traveled together, and we would go through TSA, and he would be searched heavily for his religion. He's Hindu, but I think people don't know the difference. And you and I discussed, your religion and some of the experiences you shared. And I hope we get to some positive things in a few moments, but tell us some experiences you've had, and let's talk about your religion a little bit first.
Sure. Thank you, Dr. Geer. I remember having this conversation with you, and for those of you that don't know, because we're all constantly learning every day, and that's part of who we are as human beings. I was born and raised as a practicing Sikh, which is spelled S-I-K-H. born and raised in New York, and one would think it's the cultural melting pot of the world. But I was born in a small town of Bellport on the South Shore of Long Island, about 50 to 60 miles away from New York, and that itself was like upstate New York. We all come with our hardships. It doesn't matter if you're black, white, Asian, Indian who wears a turban when they're little. We all come with our questions that we need to answer. And part of that just made me more proud and just sort of more aware to recognize that people have spiritual and religious beliefs that are important to them, and it really impacts our patient lives. I've always had a positive experience. We all come with negative experiences. Certainly 9/11 shaped my life, as is a lot of the things that are going on in the world with COVID-19 right now with some of our friends and our colleagues. But it made me just be more aware, and just more aware of just learning and educating ourselves, because we're all different.
And that's great. Rory, I know you're a devout Christian. You've shared your faith a little bit. And I know you think it's affected your patient relationships. Can you share some of the things about that with me?
Yeah, absolutely. Thank you, Dr. Geer, and really thank you to the ASPN leadership for leading these conversations. This conversation really, it's in the hearts of a lot of providers, and I'm sure we encounter these conversations in different ways, shape, or form. And really thank you guys for putting this together and allowing me to share my experience. And just following up from some of my colleagues' comment here, spirituality, I've encountered that component more from an anesthesiology resident. I remember when I met this 87-year-old lady, I got super pumped. She came in for her hip replacement, ultrasound guided IV, put 2 large bores, put the A-line. She was freaking out, and gave me DAS, gave everything to get the process going. But this lady will not calm down. And part of one of the things that I realized was I literally had to step back and ask her, what's going on? How can I help you? She said 4 words that really stuck with me, and it still does till today, and I'll tell you why. She said, please pray with me. Really throws you off, because you're curious, okay, do you want me to share my Christian faith? Do you have a special faith I should be a part of? It really puts you on a spot when you're trying to get the cases going as a resident, and also share this very controversial encounter with a patient. But I was very grateful for that encounter, because one of the things I realized was, even though I grew up as a Christian, her request at that time had challenged my workflow. It put me in a spot where, I'm really thankful for. And the reason why I'm thankful for that was because it highlighted the importance of listening, showing empathy, and really, more importantly, making sure that the desire and the need of the patients are actually addressed prior to providing medical care. And I think in the end, one of the things I learned from that encounter was, regardless of my Christian background, even if this patient was Jewish, even if this patient was Muslim, even if this patient had another religious background I had no understanding of, the key was listening, participating, and respecting the patient's need. And I'm literally very grateful for that encounter.
No, I love that. And I think we comfort our patients sometimes by just acknowledging their religious beliefs and being sensitive to their thoughts and listening. So I love that experience you've had. And I've had that experience myself many times over the years. Allison, you and us, we were at Azure together, I believe, in New Orleans, and we sat in the lobby of a hotel, and you told me a little bit about your faith. And so how has that impacted your medical career?
So I love what Rory said about listening and connecting with patients, and also being put on the spot, not quite sure how to navigate this situation. We're not taught this in medical school. We don't practice it. It's kind of up to ourselves. So it's really impacted me I actually read books and have my own personal book club that seeks to understand others better, seek to understand different faiths better and cultures, and hear from different people, so that when I do encounter people of different faiths in the hospital who request prayer from me or looking for hope, and they want to share their belief system with someone, then I'm better prepared to communicate in their language. So I think that would be that's my own solution that I use moving forward of how to connect with people and be a better clinician for each of my patients.
So that's a great point. So we have about, I guess, 5 minutes left in this panel. So I want to ask a question of each of you before we go forward, because tonight's about solutions. So you talked about some negative things, you talked about some positive things. Navdeep, I'm going to start with you, then go to Jackie, and then to Allison and Rory. Give me something as an action point we can do to better understand each other as members of our society and help each other. How can we better understand each other?
And you're saying specifically towards each other as clinicians?
Towards our religious beliefs. How is that affecting our relationships and our practices? And how can we have better unity? Because it doesn't really matter to me what your belief is, just so you're happy and that we can partner together. So any thoughts you have for tolerance among each other's ability to work together?
Yeah, thanks, Dr. Geer. So, proudly as I, wear my turban personally for that, with me, it's personally allowed me to recognize that spiritual and religious beliefs are important to many of our patients' lives, to each other as clinicians, as advanced practitioners, physicians, etc. And I think these beliefs can influence lifestyles, attitudes, and feelings, specifically about life, pain, and death. And so it's important for all of us as healthcare professionals to inquire about patients and cultural backgrounds, types of medications we prefer in their religious and spiritual system. I know in my own practice, there are some, patients that have changes in terms of the way they cope with pain, in terms of influencing opioid substances. Intrathecal therapy might be forbidden in their religious beliefs. They might reject certain medical or surgical pain interventions. We should all really just be respectful in providing the most patient-centric care that really ensures our patients' values and guides the way we clinically treat them.
Oh, great points. It gave me a flashback to doing anesthesiology and having a Jehovah's Witness child who may have had a large bleed, and I had to make some decisions. We don't have time for that tonight, but those are the type of decisions that are very complicated. Jackie, thoughts on this unity we can build?
Yeah, I mean, I think to Allie's point, one of the most important things is I think all of us are afraid of the things that we don't know, the unknown. And I think that's part of the reasons why our patients suffer, right? There's anxiety about pain. Why am I suffering? Why is this affecting me? Why was I chosen? And so I think if we all, instead of just saying like this is about peace and love and tolerance, but took a moment to understand, I mean, I think it's important to hear like about Navdeep's, history of where he grew up and like his religion and understanding those things so that people can have a greater, I hate to say comfort, but I think really it's not a tolerance, right? I think we become more comfortable with what we know. And so I think for everyone to take a moment and to Allison's point, do some not just self-discovery, but exploring of other religions, not that you need to convert or, change the direction of your spirituality, but have a greater understanding of what's out there and everyone's different belief. It makes it a lot easier to feel that sense that you expressed, Tim, which was, I don't really care what you believe, I just want to all be good. But it's easier to do that when you understand where it's coming from.
Oh, I love that. I 100% agree with that. Allison, your thoughts, and then Rory, you get the last point of this panel. Allison?
Yeah, so psychologically, one of the most innate character traits of survival in us as humans is seeking to be understood. We want to connect with other humans that understand us. And so sometimes when we don't feel like we're being understood, we try to communicate something differently or speak louder, or we seek out other friendships that might be better, when I think I try to say, how do I seek to understand someone else? And that will make them feel safe and comfortable. And when people feel safe and comfortable, they're more open to interacting with you. So I think one of those take-home messages every day, there's 365 days in a year, so I try to say each day I can try to seek to understand someone of a different culture, religion, race, ethnicity, and background, socioeconomic or whatever, so I can be more informed.
So what's really cool about that, I hope that every day, we get to understand each member of our society better. And we have a lot of days and a lot of members, so that's wonderful. So thank you for that. I agree with everything you said. Rory, you get the last point of this panel before we move on to the next panel.
I can only agree with Allison, Jackie, and Navdeep about this issue. And the way I look at it, it's really straightforward. Listen, act upon it, but listen one more time. And in the end, in my mind, it comes down to a couple of things. I hear you. I could never understand what you're going through, but I hear you. And I think in the end, that goes a long way, partly because even as a Christian, taking care of another Christian who's about to go to surgery, I have no idea what else they're thinking about. It's beyond just faith. It's beyond socioeconomic status. It's beyond multiple complexity. But the I hear you and the listening component, it is so powerful, and it's okay not to have a solution. And again, I really appreciate this conversation and looking forward to hearing from our other colleagues.
Well, we're right on time. That was a great discussion. And I think that's very great. So I want to thank the four of you very much, and thank you so much for coming tonight. I'm going to bring Natalie back for a second with Krishnan. And Natalie, before I go to the next panel, I want to get yours and Krishnan's your take home from that religious discussion. So Natalie, what was your take home from all that?
I think what really struck home for me is the ability to listen. I think physicians and people are often afraid to misstep, even if there are good intentions. So that may cause someone to avoid engaging in a conversation where they don't feel very knowledgeable when you're used to being an expert in something. But I think the point of, you don't have to understand, you just have to listen and hear somebody, and being comfortable being uncomfortable, I think is going to let people go a long way just with that effort of understanding. So I really appreciate that point.
No, that's a great analysis. I love that. Krishnan?
I'm going to be more simple. What an awesome group of new pain docs that are coming out into practice. I mean, you know, who would have figured that we would get this kind of panel, and just the amount of thought that goes into how do they reflect on their everyday life. Really impressed, and glad to call them my colleagues. So
yeah, great. And I'm going to quote my favorite rapper, Tupac Shakur: "Only God can judge me." So that's the message for me for the religious panel. You know, be kind to each other, let God judge the person if they believe in God. So that's it. So thank you both for joining me for that. I'll go to the next panel and then bring you back, and then I'll turn over to you guys to moderate. So I'll have my race panel come on. Before we get to the race panel, so I hope Eric, Jonathan, Shawn, Mark, and Lawrence can join me. Before we get to that panel, I want to make just a comment about our disabled colleagues, because we don't have a panel on disability tonight, but I think that's another important group I want to mention and acknowledge before we move on, because there's a group called the Challenged Athletes Foundation. And I donated last year $7,500 to that charity, and the amount's not important, but the fact that bought a wheelchair to race in for an athlete who had paraplegia. So we have a lot of disabled colleagues in pain medicine too. So while we didn't have a panel about disability tonight, before we move on to our next panel, I want to acknowledge the importance of being kind to her and to being inclusive of our disabled colleagues. And I think in a future webinar, we're going to cover that topic as well. So I didn't want to leave forward without acknowledging that for our colleagues. This panel is very important today, but it's very important every day. And it was important a year ago, and it was important 10 years ago. And I think we want to hear each of your experiences. And I think we want to talk a little bit about the issue of race and its effect on medicine, its effect on our society, or its effect on pain medicine, and its effect on our relationship together as we go forward. Jonathan, I'd like to start with you. You came to visit me from Arkansas, the great state of Arkansas. And we talked a little bit about this over dinner, in not great detail. So I didn't really get to learn as much as I should have probably. So I'd like to have your thoughts tonight as we start.
Sure, I really appreciate you guys having me and for putting on this panel. I'd like to speak from my perspective from being a physician and also being a patient. So when we think about what a physician does, especially a pain physician, we take very personal information and we combine it with our knowledge and expertise and work to improve quality of life. And there is, unfortunately, a section of the population that believes that people, because of their race, their gender, their religion, their sexual orientation, are not trustworthy, not intelligent, or uneducated. And if you believe that, it makes it very challenging for me as a Black man to be someone's doctor and to do those things that I need to do to improve their quality of life. And so it's something I've encountered. And when it happens and you don't get that buy-in, you can tangibly feel it. You know, I'm from the South. I was born in Memphis. You know, I was raised in Arkansas. I live in Arkansas now, but I also did a lot of my training in New York City. And I felt this in both places. And so it's not a Southern thing. It's not a Midwest thing. It happens, you know, on the coast also. And I've also felt it from people with different backgrounds than I, but also people from the same background, because we all are subject to biases. And so I really think it's our job as physicians, because on the other side of that coin, there's a patient, right? And we all want our patients to have excellent care. And so it's our job as physicians to really make sure that we are able to protect our patients from our biases so that we can ensure that they get optimal care and that we don't hurt them.
Jonathan, I want to ask you a follow-up question, and then I'm going to go to Eric Lee next because he's going to answer the same question I'm going to ask you. You were an athlete, okay? And I grew up in a small town, and my town was kind of unique in that we were a coal mining town. We were 70%, 60% white, 40% African American, and we got along great, I thought. So in sports teams, I always felt more united. Is there something real about that, or is that, do you think that's not real? Is it a falsehood we have that we're all together because we're on the same team? How do you feel about that?
I think it's real because it's about comfort. And I think that we all have to learn to be comfortable with discomfort. You know, I know you're an extreme athlete, and I'm sure there are moments when you've been uncomfortable, but they make you stronger, they make you better. And being around people who aren't like you, being around people who don't think like you and who challenge your way of life or your way of thinking, it's uncomfortable, but it makes you stronger. And so I really encourage everyone to spend time with that discomfort. If you're in a room and something uncomfortable needs to be said, please say it. And get used to that discomfort, because it'll all make us better as physicians and better as a specialty. So
Jonathan, your answer was so good. I'm not even going to ask Eric the answer because it was the right answer. But Eric, I am going to come to you next. So Eric came to visit me. Eric played football for Yale, I believe, and for the NFL. And I have a friend who was from the Pacific Islands. And I thought that Eric was from Samoa. And I said, what is your ethnic background? And I think Eric was so used to people being racist to him, he thought I was asking that for a different reason, but I thought you were from Samoa, Eric. So our discussion started with race almost immediately, and it turned out to be one of the greatest friendships I've ever had. You know, you and I were very close. So what's been your experience in medicine? What would you like to share with us tonight?
No, thank you so much. I remember that visit well. And again, talk about biases, right, from the experiences we have. And I learned a lot from that. And, you know, the fun part for me overall as a whole, speaking on this panel, first of all, is just, I think that it highlights the great part. These are not just my colleagues. Everybody on this is my friend. Shawn has been my friend when I was in New York. Mark is one of the most thoughtful people I've ever met. Lawrence is a mentor and a leader of mine. And Jonathan I've gotten to know recently. And he summed up, you know, pretty much a lot of the Black experience in medicine and even in this country very well. So I'll kind of leave that for, you know, him and Lawrence to discuss. I think, you know, the great part about life experience is diversity. And one of the challenges we have, unfortunately, is there is a woefully apparent systematic approach, not only to minimize that, but also to proactively dispose of it. And that's what attracted me to medicine. I think medicine is one of those universal tenets of humanity and one of those great fundamental rights where you treat people of all backgrounds and give everybody a chance to feel better and care for them in their times of crisis and need. And that was one of my original, you know, attractions to the field of medicine. When I look back at my own personal experiences from where I grew up, was kind of not just amazing from a survivability standpoint, and Lawrence and I relate on a lot of issues on that, but just even from some modicum of success. It's nothing short of a miracle that I'm here today, and that's with conversations and help from people like yourself, Tim, and having conversations with people like Lawrence and Shawn and Mark, who's gotten me to where I am today. And so, you know, I think the biggest challenge we have, even at the places of quote unquote success or higher education or learning, and especially in our field of medicine, is the awareness. There's a dearth of awareness of understanding the depth of the problem. I mean, I was at Yale and I read the La Amistad papers and was in the New Haven courthouse. You know, when I was in Boston for medical school, I saw Faneuil Hall, which was built on the wealth of enslaved, you know, Africans. And it was actually the first state in this, or the first territory in this country that legalized slavery was Massachusetts. And just the lack of awareness, even at places of higher learning, makes it impossible to address those challenges of those deep-seated challenges in the system. And so kind of, with that as the background, one of the things I want to highlight a little bit in my few minutes here is the Native American experience, and especially in terms of healthcare. For the state of California, which I'm in now, back in the 1700s, there's about 300,000 Native Americans, and in 1850, shortly after they discovered gold, they passed the Government and Protection of Indian Act, which the population was around 250,000. From the passing of that act to just 50 years later in 1900, that population went from 250,000 to 20,000. It was so bad, the egregious atrocities during that time, that actually this past year, Governor Newsom issued a proclamation and apology to the Native Americans to address some of those issues. So the challenge is, the systemic background is there, and what does that relate to healthcare? Some people don't quite understand the tangible reality of that. And it comes down to resources and finances, unfortunately, a lot of times. And in this country, just looking at things, if you look at the Department of Health and Human Services from 2016, the average Medicare patient received around $13,000 in financial bill funding. Federal inmates received around $9,000. Medi-Cal and Medicaid patients received around $8,000. And those are disproportionate a lot of times in inner cities to minorities, mostly Black and Latino in California. But the Native American population received $2,700 per person. That's geographically distributed and cross-measured. So the difference in disparity of resources is dramatic, from 12 to 13,000 for Medicare patient to 2,700 for the average Native American in terms of healthcare finance or spending in this country. So without those resources there, and without addressing that issue, and without having the conversations that we're having tonight, which I'm greatly grateful for, it's going to be hard to address those things. And that's kind of the reality of where we're at. And I'm disheartened by things that have come to pass, but I'm excited to have these platforms that you've given us here to have an opportunity to bring awareness to these things and create conversations so we can change things going forward. So that's pretty much just what I want to say now.
Eric, I never saw that coming, brother. That's so great to talk about the Indian experience, because right now I'm speaking to you from Kanawha County, which is an Indian word. This was an Indian community in West Virginia many years ago, and now there's several of us who have Indian blood in us, but we don't ever realize the discrimination that occurred then. So I think it was wonderful you brought that up. That's something I never even think about, and that's bad of me not to think of that. And so thanks for that's a pearl that we all get from this webinar that none of us expected. At least I didn't expect. And the numbers you quoted were very good. So it makes Shawn Lee have a difficult time because he's next, and you quoted some real numbers. So Shawn, here we go. You and I had a discussion in Austin, Texas over dinner. And so one of the reasons I invited you to be on this panel, along with my colleagues Christian and Natalie, was you told me about a very bad experience you had as a Chinese American when you were in residency. So that was one of the reasons I thought this panel was important for you to be part of, because you've experienced firsthand medical-based racism. So I don't want you to make you emotional or upset, but you want to share some of that with us, and maybe we can learn from that.
Well, thank you, Tim. I think, again, I wanted to thank your leadership and Dawa's leadership for taking on such a bold step. With all the recent events that's happened, I texted you recently, and I said, seeing images of medical workers, healthcare workers at a particular institution taking a knee hit me pretty hard, and not for the same reason everyone else may think. It's, as you guys all know, I've been adopted and embraced by the small family of anesthesiology and now pain medicine, and I've never felt so loved and cared for and respected. But my previous career was a little different. We now talk about the common language of science, medicine, where truly all of us operate and we cut a patient open. Everything looks on the inside looks exactly the same. Everybody bleeds red, and we all look the same on the inside. But unfortunately, we cannot escape some of the flaws of humanity. So I remember kind of this is a little bit of a PTSD coming back, but being in residency, first observing things that happened where folks are a little bit older in generation and not as, I guess, explored or learned in terms of the worldly events would characterize foreign residents. These were foreign residents from the Middle East, and we were going through the Iraqi wars, and literally these attendings would call my fellow residents terrorists, and they would name them certain terrorist names. And this would go on, and people didn't correct anyone. We just kind of went along, and and everybody was understanding that we were at war with the Middle East, and it was okay, but it wasn't. It wasn't okay until it happened to me, because when they start making remarks about, certain stereotypes about Asians, you realize how bad it feels, and no one stood up for me. But now that's different. I got embraced into this world, and you thought Eric was Samoan. When we first met, I thought he was Korean from another mother, and went to a Korean restaurant in the city until I found out from getting to know him. And so I think we make assumptions. So when we make assumptions, bad things happen, and we don't learn. We need to self-educate and learn from others, and that's where meetings and conversations help us improve. So literally, just this happened this evening, and I think I was at the beach taking my kid to the swimming practice, and because their indoors practice is closed because of COVID, no one was wearing a mask, including the coaches and the students. And this female mom came up to me and said, "Can I offer you a mask?" And I looked around and said, "No one's wearing a mask, and she's not offering anybody else a mask. No one's wearing a mask. Why am I being offered a mask?" Then I looked around and said, "Wait, I'm the only Asian guy here." It didn't hit me until afterwards. But the thing is, if you're faced with that situation, the question is, do you stay quiet or do something about it? I think the recent events really has inspired me, saying that being the model citizen, it's not enough to stay quiet. It's not enough to tell your kids to study harder, but we have to teach not just our kids, we have to teach our young fellows and residents to speak up. When things are wrong, and keeping it quiet only makes it worse. So we need to get it out in the open, talk about it, and recognize. And so just carrying on with uh, Rory said earlier about listening, I think this panel is about speaking up. So when you recognize something, it's time to speak up. That would be my
Right.
message.
Shawn, that's I love the story. I would have told everyone to put a mask on because I'm scared of dying here. So that would be my advice. But thank you for that. We have about 6 minutes left. So I have 3 minutes for Mark and 3 minutes for Lawrence. I'm trying to give everybody about 3 minutes. So I'm sorry for the time that's, I've saved Lawrence for last because he's the wise sage here with me, and I have a very specific question for him. Mark, you and I, we shared the Conor McGregor Floyd Mayweather fight when I had a pneumothorax and broken ribs. So that was my experience with you. But we also shared experience where sometimes you're a white man, in America in medicine. So I guess the question always becomes: is that a privileged position, or is there issues for you too? Do you experience any type of feelings of bias against yourself?
Yeah, it's a very complicated situation, even more so now than it ever has been. I think ultimately, the way I approached medicine was originally it was based on a personal desire to be like my father and some of my family that had early struggles, but were really motivated to ultimately succeed long term. And my personal background, when I came into this, I really wanted to be a servant to humanity. I mean, that really is the truth. I really wanted to be a servant to not only the patients but also my colleagues. I watched many times trying to shadow and understand, do I fit into this world of medicine or not? And I found that there were a lot of personalities that I didn't particularly care for. A lot of people that approach medicine from a pedestal. And I saw how it could negatively affect people and how they are perceived in terms of their care. And that really impacted me because kindness and love and understanding are so important and a very important part of healing. I just want to say thank you to the society for putting this together, because I think it's very important. Ultimately, my personal background, I'll keep it very brief. As the white male on this panel, I'm actually first generation in the United States on my father's side. He was 30 years older than my mother, and he was a concentration camp victim in World War II. So my dad, if he were alive today, would be about as old, if not older, than everybody's grandparents here on the panel. He died before I became double digits. He struggled learning English. He was trying to catch up in life a little bit. And when he finally learned English, he found his way to Charleston and Cleveland and completed residency, and ultimately met my mother, and here I am. But the immigration component of being a white male is often lost. I think it's assumed that I just was born into something and here I've been for generations and generations, but it wasn't in fact the case for me. When my dad died, ultimately he left 2 small children to my mother, and we were not exactly well off. And so early on in life, not only did I realize I wanted to be like my dad and try to carry on what he was not able to, but also the importance of being humble and understanding what hard work is all about, what low socioeconomic status is all about. And when I take care of my patients in Appalachia, there's poverty there that I never even thought would exist in the United States today. But I think the importance of understanding that being poor has no color, being disadvantaged has no color, and where you come from means a lot. And I really believe that working hard in servitude of our patients, in servitude of our colleagues, is so important. I spent a lot of time in residency thinking about what I could do to show my gratitude to my dad, who stuck his neck out, had us, and all he ever wanted was an American child. And I happened to be one day in the ORs at Ohio State, and I met this man who was, he'll go by the name of Nader. And Nader, after a while of getting to know him, he was actually a physician in Iran, but he was struggling so hard to get to gain traction in the United States. And I looked at him and I thought, wow, I wonder if this was a lot of what my dad went through early on. And he told me that, you know, as he was working as a surgical tech and people were throwing things at him and making, you know, demeaning comments in the OR and the caustic atmosphere that it can be, I just felt so heartsick. And so I started studying online. How can somebody like him get traction back in the United States and go on to be successful? And I found this program that was an osteopathic program where he could convert from an MD to a DO through New York Institute of Technology. I'll keep it short. He did it. He went to he went on to become enrolled, but in order to do that, he had to live in his car in New York City. He took loan money and sent it back to Ohio, where his family could still survive. His kids could graduate from high school, and he slept in his car for 2 years and washed up in the locker rooms of the medical school just to survive. And ultimately, he is now a practicing physician nowadays. And I love him with all my heart. I think of him all the time, and I think of my father. And when I wear this, when I get in engagements where I feel there's such important conversation and I need motivation, I keep something on me that's red, white, and blue, or something that's motivational to what I think of as a struggle ultimately for success. And so that's why I wore the bow tie tonight. I'm just not just another nationalistic white person, but actually somebody who really looks at America and all of us as the same. And if we work hard, someday, maybe 20 years from now, we'll all look at each other and to not see any color, any race, any sex, anything like that, and just love one another and promote one another and be servants to one another.
So Mark, thank you for those comments, and great story about your colleague who made it through medical school, and it shows how we influence others. And I think you've been an inspiration. Lawrence, I saved you for last for a very specific reason. You know, you and I have known each other many years. You're very professorial, and you've been a professor at UCSF for a long time. And one of the things at the end of this, and we're right on time, we have about 3 minutes left in this panel, and I saved them for you because we're going to talk about maybe helping some people that are students or residents right now who are students who may be diverse and need maybe some mentoring going forward. If you were a young person today, and you could go back in time and write yourself a letter, and now you were going to be a resident again, and you're still a very young man, so that's possible, I guess. But what would you recommend to that diverse resident, man or woman, coming up through residency now, knowing what you know now, to help navigate all these issues that Jonathan and Shawn and Mark and Eric have brought up? How would you navigate this today?
So I think it's critically important to keep an open mind and recognize the history. I'm glad that Eric brought up some history. I just recently learned, and I couldn't believe it, I'm 62 years old and just recently learned that Abraham Lincoln supported white supremacy and segregation. He something that I wasn't taught when I was growing up. And I think the conflicts that have occurred in the past are extremely important to recognize, but also recognize the future that you want to have, and recognize that these are issues that cannot be ignored. When I look at our country, I often compare it to the Holocaust and apartheid in South Africa. And what I see a difference here is that they've embraced their social strifes and struggles and faults and tried to bring that to the forefront of their education and exposure to their young people. And I think we are still just trying to get over that and trying to sort of bring that. And that's why situations like this bring that to the forefront. And once you bring that to the forefront and you understand that history, then you can understand how people are, how they think, and try to engage with them and change that. I'll give a quick story. Being a Black American and the brunt of violent assault by not only police but also by crowds of people with guns and chasing me out of various towns in the West and the Midwest and the South and the East. Doesn't really matter. And as you said earlier, that's just a part of being, in my mind, just being Black in America still. But that wasn't the lesson that I found most interesting, because I figured that's just part of being Black in America. My most influential experience was actually in grad school when I was in a room and I just happened to be talking about my professor's new car that he had just brought over. He had done a sabbatical in London and had a good deal on a BMW. He was Chinese, and the other person in the lab was from Taiwan. The other person in the lab was Jewish. And that inherent bias became so clear to me when I talked to them about their choosing of cars. So he came back with a German car. The Jewish worker in the lab said she would never buy a German car because she didn't buy anything that was German. She bought a Toyota. The woman from Taiwan said she would never buy a Japanese car. And I looked at it, I said, really, I can see how these inherent biases are prevalent with everyone and for various reasons, understanding their history. And you understand that and bring it out in the open and discuss it is critically important. As a professor here at UCSF, I see racial bias on a regular basis. And I see it among the residents and fellows and attendings. Very few, I would say, are blatantly bigotry and hateful, but the institutional and the inherent biases that people have is very present. And I make it a point to point that out and to show fellows and residents how to recognize that and to address that. And once you can recognize it and address it, then maybe make some actions toward corrective actions on how they interact with patients. So it's critically important to first and foremost recognize that it's there, everybody has biases, and then to compensate against it. And for most of us in the panel here, if I'm not mistaken, we're all anesthesiologists. The first thing I learned, no, I'm sorry, Eric, I apologize. But one of the first things I remember being taught was that there's two types of people in anesthesia: those who prepare incessantly and just never get the case done, and the other who never prepares and doesn't have anything ready. And neither one of these extremes are the appropriate way to be, but if you understand what your tendency is, then you can work toward reversing that tendency. And so I was the one who liked to be prepared, and so I knew I had to hurry up and get my case started, so I would recognize that in my own behavior. And so understanding what your biases are is critically important, and that's how we can move forward and continue to learn and to continue to teach our children and those that are in our tutelage as well.
So Lawrence, saving you for last was brilliant, because I'm giving myself credit because that was a great point. And I love your story. I love what you said. And as always, you give great insight. And I think we all have bias, and we need to understand those biases and be kind. And so thank you all very much for joining this panel. I think it was a great discussion. I wish we had 10 hours instead of 15 minutes for the panels as we go, but we're going to move on to the next panel. And thank you all so much. And look forward to future comments in the newsletter. I'll have Natalie and Chris join me again very quickly. Chris, thoughts about the race panel before we move on to the next 15 minutes on gender and sexual orientation?
Yeah, I mean, I think one of the key take homes again that has kind of come up again is about awareness and knowledge before you propose solutions. So I think that really keeps to all of those comments are really relevant. I don't know, Natalie, what you thought about that.
Natalie?
I definitely agree with you. I also really liked the point not being afraid to speak up, whether it's to residents and fellows or even a colleague, the person who's experiencing the aggression or the microaggression or whatever it is that the person delivering may think is in good faith or even a joke. It may be easier for somebody who's observing to respond than the person who's experiencing it. So I think that's a very important point to encourage people to speak up and speak out.
So I just want to say I think that panel was amazing, and I learned a lot from everyone on it. And I think again we need to keep learning from each other. And so we're coming to solutions at the end, but so the last 15 minutes will be solutions. The next 15 minutes, so Natalie, is in your hands. So we'll look forward to this discussion.
Well, thank you so much, and it's my absolute pleasure to be moderating this panel on gender and sexual orientation. I know we have an absolute rock star lineup of speakers here, and I am very excited to listen to what you all have to say. Dr. Esposito, I think we're going to start with you. So if you would like to go ahead and lead what your thoughts are, and we'll follow up with some questions.
Well, again, thank you to ASPN and Tim and Krishnan and you, Natalie, for moderating this. I think that it's really important to have this discussion. When I look at gender and sexual orientation, the word that comes to mind immediately is community. And I kind of separate this into two. One, the patients that are within our community, and then two, the physician community. And so I think it's really important to understand the stigma and discrimination that affects LGBT individuals, and to understand the disparities within this group of people, because understanding this will help us become better physicians in order to treat them. So, especially in the pain community, LGBT individuals suffer from a greater degree and prevalence of depression, anxiety, substance use, suicide, right? Access to care is more limited. There are all these issues that if we are able to become more familiar with, I think we'd be able to better serve our patients. On the physician community side, I have my own experiences going through college and medical school and residency and ultimately in practice. But one thing that I think has been identified is that there's been this subtle devaluation of LGBT individuals, whether it be with casual comments or jokes in the OR or innuendo. These things really set the stage. And unlike some other groups of people, LGBT individuals don't have that immediate sense of community. We don't necessarily have a mother or father that is gay or lesbian, or a sibling or other people in our class. And if we do, we may not know it. And so there's an isolation to this. And there was a study done in the Journal of Academic Medicine back in 2015, which looked at this within medical school and residencies. And they estimated about a third of LGBT med students and residents acknowledged being subjected to offensive comments. And a third of these individuals had declined to even come out and make it known that they were LGBT. And they cited that they just felt a lack of support from their faculty and their peers, in addition to concerns about how this might affect their career prospects. So a big feeling of alienation when we as Mark said, servants to our brethren, that's a real shame. And so my goal here is, and in the next panel, is really to come up with a call to action. What can we do? One, I think it's important to realize that words matter, right? So educate yourself. I challenge everyone here to look at some of these resources. Kate Meacham was nice enough to email me earlier today and came across some resources that I'm familiar with, and she's like, we should share these. And I said, this is great. So there's some handouts that are available through this webinar. I would also challenge anyone that's watching this webinar. I challenge you, if you are LGBT, come out, because LGBT individuals, whether it be within medicine or our patients, we don't necessarily have obvious role models. And it's really important, whether it be growing up and doing sports or in our career, to have a role model or a mentor to look up to and to help direct your career path. And if you're not LGBT, we'll be an ally. Engage us. Try to relate. Ask questions. Ask the same questions you would ask a straight person. Oh, are you married? Oh, what do they do? How'd you meet? I think this is all about building that sense of community. And then, understand the issues facing LGBT patients, right? Look at these resources. Create a safe and inclusive environment. The AMA, the AAMC, they have great resources, whether it be just posting signs in your practice or being familiar with certain terms or learning how to ask questions that create a welcoming environment. So again, it comes down to community, both the patient community and the community of our fellow physicians.
Thank you very much for sharing that. I love your message of connecting to community, whether that's as a member of a community coming out of isolation to join in the support of a community, but also being visible. I felt that often as a woman, going for things and agreeing to be part of things because I want to make sure that somebody who is following my footsteps can see a female in a leadership position. And, I think it's important for every community, and I appreciate you bringing that to the table. So thank you so much for sharing. I believe we're going to Dr. Peterson next. I know, Dr. Peterson, you had some stuff you wanted to talk about as far as research, not only sort of the pipeline of women in research, but also kind of the focus of research and how there are some gender disparities there. So I'm really looking forward to hearing your take on the gender bias and how that can affect research, both in carrying it out and then also who's given credit and the opportunity.
Thank you so much. And I think that, again, part of this is the push for representation that Dr. Esposito was just talking about. Populations that aren't necessarily in the mind of the people designing the research will not be represented in the study. And so if a steering committee for a large clinical trial doesn't involve the appropriate representation or those who are allies and are thoughtful about that population, the research impact and its outcomes and how it actually impacts our patients in the clinic will be less valuable. So, for example, there's several medications that have come out recently even where women were not included in the study to enough power to say that there were dose efficacy guidelines that could be concluded from the trials. And certainly historically a lot of research studies have been done just on male populations. So what do we do when maybe 60% of our practice is women and we don't have evidence basis for using those medications and using those in appropriate dosages that will be effective to those patients? Additionally, there are some female predominant disorders, and if we don't push to do the right kind of science in those areas, we will be leaving behind a large number of maladies, and then the labels of the histrionic patient who has fibromyalgia becomes a dismissive label as opposed to something that is based in science. And thankfully, we've seen an improvement of that in the past decade. But without pushing forward to the representation in science, we won't see that. The other piece of that is what I alluded to, which is that we need the science leadership to be representative in order to push it. That means that the design process, the push for funding, the review of that and who is on study sections nationally for federal grants, who is involved in determining who provides grants out of industry to make priorities on research as well, and who is the face presenting these at conferences. There is real bias on the dais when it comes to presentation. And one of the most important things that we can do is to look around and make sure that we are pushing for the diversity of thought and of investigation, because knowledge comes from having a heterogeneity of experience. And the more that we ask those questions coming from heterogeneous background, the more advancement we'll make.
Thank you so much. I'd love to ask a follow-up question for the pipeline issue. And I know that's something that we've kind of discussed before, even outside of this webinar. What do you think is when there is the issue brought up that there just aren't women in the pipeline? Do you think that's truly a supply issue? Do you think that that is a lack of effort? Do you think it's just a blind spot? What do you attribute it to, and do you have any advice for efforts to be made in that direction?
I think, first of all, one of the keys here is to make sure that women are welcome and that other groups that we're talking about are welcome. And it's not just about, oh, we invited 2 people and they declined and weren't available, but the theme of the meeting, the attitude of the organizers, the venue, whether or not a social event happens in a smoking area or somewhere that's family friendly, for example, all of those are subtle cues which will suggest whether or not somebody actually should participate. One of the biggest innovations in the past few years has been the inclusion of childcare facilities and lactation stations at meetings back when we had in-person conferences. But what that does is it facilitates and understands that parents would like to attend scientific meetings. And by making the structural changes that welcome parents, and notice I didn't say mothers, but parents that welcome in those areas, that enables more participation. And so it's not just about looking for people and inviting them and encouraging and sponsoring people forward, because the leadership challenges are large, and I can't wait for Dr. Vanderpool to talk about that more, but also about changing what the structural setup is so that those small implicit biases aren't there.
Thank you so much. Excellent points. And with that lead in, I know Dr. Vanderpool, I know you had some things to talk about: leadership, sponsorship, promotion. So I'd love to hear what you have to say. Oh, I think you might still be on mute.
Thank you. It's interesting, when I was preparing for this panel, I was thinking about the importance of being able to see role models in positions that make decisions. And so as a Black female physician, I have had few very instrumental role models, but those who I was able to see that looked like me were quite instrumental in my decision to take the path that I took. At the same time, I have recognized how important it is for me to continue to advance, both in terms of ideas and in terms of influence, so that others who are coming up behind me, beside me, can also continue to aspire and see that the path can be cleared. A couple of things that I wanted to talk about before we get into some potential solutions are some of the challenges that we face that limit females or women in leadership in particular. And some of them actually start internally, with women having imposter syndrome, thinking that we are somehow not good enough or somehow not of the level that we need to be. There's data that suggests that women feel that they have to meet greater than 90% of the criteria for job description before they feel that they can apply, versus men may apply for the same job meeting only 50 to 60% of the job description criteria. And that's something that we as women who support each other have to encourage each other to get past. That's why the communities that we have, such as Women in Neuromodulation, the Society of Women Innovators in Pain Management, AMWA, many other societies that support women and women in leadership, is so critical for us to participate in. And I highly encourage, if you do not have a community of other like-minded women that you can communicate with and collaborate with, and they don't just have to be physicians, but if you don't have a community of women that are striving to better themselves and advance their position, I highly suggest that you find that community. The second thing I want to talk about is a little bit more subtle, but we have to acknowledge it, and that is the microaggressions that women feel or experience in leadership. These are the comments, the lack of acknowledgement, or the somehow dismissal of something that might have been accomplished that would have otherwise been recognized by a male colleague, that the woman somehow either has to blow it out of the water to where you cannot deny it, or in some other way it's not necessarily acknowledged to the same level. We have to call that out, both our male supporters and colleagues, and we have so many he for she members on this panel and in this society and community. We're so grateful for that, and we need to continue to advance that for each other. And call those out when we see them. And I'll tell you a personal experience that I have, which is that Naming something a microaggression actually takes away its power from impacting you personally, rather than just wondering, am I going crazy? So I highly encourage you to recognize microaggressions when they occur and call them out for what they are. Whether you call it out to the person that is doing it to you or whether you just call it out to yourself, it will be very, very freeing. The third thing I want to acknowledge is the importance of sponsorship. And that does not just mean female sponsorship, but that means the sponsorship of others who are ahead of you in terms of influence, or might be alongside you in terms of equal striving for what you're trying to accomplish. And that means that somebody is willing to put you up, not just mentor you, but put you in front of folks who make decisions as a suggested leader or somebody that might be able to contribute to whatever the cause might be. And then finally, we must reach back. We must be mentors. We must reach out to those who are coming alongside and set the example, but be accessible and be engaging with those who are trying to advance within the leadership sphere, so that we can continue to elevate the diversity, the inclusion, and the opportunities that are abounding for all female, all LGBTQ, and all of the diverse populations that can really contribute to improving the status of healthcare and so many other institutions within our communities.
Thank you so much for those thoughts. You know, I think a lot of people in this space are very familiar with the terms he for she and allies, and I think that's an important thing to really share, because it's not necessarily coming from a point of being angry or disappointed, but you know, we want allies, we want people in this space, we want people contributing and becoming engaged. So I encourage anybody who's not overly familiar with work in this space to consider becoming an ally, consider becoming he for she, or just getting involved in this space in general. So thank you so much, Dr. Vanterpool, for your thoughts. And last but definitely not least, we have Dr. Meacham, who will be joining us with some thoughts on the project Implicit, with implicit bias, as well as sharing some personal perspectives on this space. Thank you.
It's so great to hear each of your perspectives. I'm also super grateful for the role of women in neuromodulation, and I mean that in the larger term, but specifically women in neuromodulation and what NANS is doing, but also women innovators in pain management. And my role as a pain physician and as a researcher has changed so much and has developed so much because of that community that came up before me and has lifted me up. And it's so great to hear so many of you on this panel, this particular one, but also I can't think of any of the leaders within ASPN who have not been aggressively promoting my career, especially because I don't necessarily look like the typical pain management physician or engineer or researcher, and that's been fantastic. And so, but I really wanted to focus a little bit on some things that Dr. Esposito already identified, and I just thought maybe handouts would be something we could focus on in terms of something to do. And these things are in the handouts, and they focus on two things. One is it's from the American Medical Association, and it's a sign that you can put out that says that we don't discriminate against, and it has the list of things that we don't discriminate against. And it's, I think, important, especially in this environment where there is so much, there's a lot of pain coming down the pipeline, and it's going to roll down to the same people who are vulnerable in the same situations. And there's a lot of hate and separation, and I think that we all understand that it is our role as leaders and doctors to battle that. It's not just us, and Dr. Gore mentioned this, he's mentioned a lot of very important things, that we're not the only ones. We are part of the team who sees our patients, and it's really, it's about the patient, and we play a role in their human story, and that's a privilege, and we have a responsibility, but it's we have an opportunity to be more proactive, and these handouts talk about how to do that, both in terms of making sure that people can see when they come in that you are intentionally not going to be discriminating against them, and then also having conversations, so providing inclusive services and care is from the GAP. It's from an institute, and it's an important one, about including language in terms of how your staff is going to ask questions of your patients being sensitive to how they identify. And that's going to be super important in this role coming forward. In terms of, like, I think there's a lot of things that we can actively do, but making sure that we are proactive, because a lot of the patients who are reaching out to, that we can reach out to in terms of greater access with telemedicine, have also learned, and rightfully so, to distrust the system. And so it's going to take more than just intervening when we see it. It's going to take reaching out to them and saying that we are your ally, and we understand that you are coming at serious disadvantage, and we have educated ourselves, and we are here for you particularly. And so those handouts are part of it. I think the newsletter will be part of that too, and an ongoing call to action and dialogue will happen. It's a real privilege to be part of this group.
Thank you for your comments. I'd just like to invite anybody who wants to share a personal story of an ally or a sponsorship or something that kind of came in a moment when maybe you felt personally in a position of experiencing bias or a discomfort due to a microaggression or a micro insult. If anybody could share a story of an ally coming forward just to sort of share an example of what that might look like and what it did for you as an individual.
I have something really small, which is that I've been really honored to be on a lot of panels like this. And often I'm the only female face in a group of men. And I'll be introduced as Erica along with Dr. So-and-so and Dr. this and that. And when one of my friends on that panel says, well, actually, Dr. Peterson would like to say something, it is calling out that microaggression and making sure that we remain on equal footing. And I can't tell you enough how important it is to validate each one of us for the professionals that we are, for the expertise that we have, regardless of what our background is. And that applies to all of us on all these panels, and because we all have our own diversity differences, to make sure that we hold each other up and then lift each other forward.
Thank you for sharing, and thanks to everybody for this panel. You guys all were so fantastic. I really appreciate your expertise.
That was an amazing panel. Thank you very much.
Yeah. Okay. All right.
So now I just want to make a few comments about your panel. I think it was amazing, and of course I love all the people on the panel. I think one thing I want to point out is sometimes there's a mantle, and I recommend that we put a few very talented women on those panels, and they're invited and they decline, but they don't advocate for another woman. So I will tell you, if you get invited to be on a panel, instead of saying no, I'm not available, I would love if you would start to say, I'm not available, but this other young, talented person is. I think that's very important, because I see the final panel and it's all men, and I say, I thought you were inviting so-and-so and so-and-so, and they'll say, oh, she wasn't available. And I said, well, did she recommend anyone else? And the answer is always no. She just said she wasn't available. And so I think it's important that you sponsor each other and help with that diversity issue. Secondly, I think it's important for men, when they're on a panel of all men, they should at least try to make it diverse. Now, sometimes that may not be possible, but it's getting more and more possible. We saw the talent here, and that shows you it's more and more possible. And lastly, I want to share a quick story about, and we have about 15 minutes left for the last panel, but Mike Esposito said something that I want to bring this back to Michael. Michael shared a story with me about his marriage when we were in Barcelona together, I believe. And there was a doctor named Joseph Giffen who was kicked out of medical school at West Virginia in the 60s for being gay. And he got back in medical school and he became a professor at SUNY Downstate. But he shared that story with me when I was probably about 16 years old. And I was amazed that you would kick out of medical school for being gay. So I think we've came a long way, but I think we have a long way to go. So that's just some personal thoughts. Krish?
Yeah, I mean, I'm with you, Tim. This has been an amazing experience, and I think I'm humbled in the amount of things, recognizing how much I have to learn. And I think each of these interactions and so much of that, taking copious notes about all the things that, whether through different opportunities that we can offer. Yeah, my words are minimal, because I think at this point, taking all this in and trying to act upon it is a really important part of the next step. So I really
Natalie,
appreciate all this.
what was the most important point of that panel before Krish leads the last panel, which the three of us will stay on? What was the most important point of that panel that you just led? You're on mute, actually.
To me, it's really the allies. I don't think I'm on mute. Can you hear me now?
You're good now. Yeah, you're good.
Are you able to hear me?
Yes.
Oh, okay, great, thanks. I think that it's the concept of allies and community. I think both with LGBTQ, both with women in medicine or whatever, diversity that you're bringing within your own experience, it's important to find a community that understands you, that you can draw strength from. Sometimes the weight is heavy to carry. And I think when you can share that with a group who understands you without you having to teach, that's a really powerful place to sort of rejuvenate and just share ideas in a very safe place where you don't feel like you're weak, you don't feel like you're complaining, you don't feel like you're going to offend anybody. Dr. Meacham mentioned women in pain management. There's also the GRIT conference. There's also women in neuromodulation. But I think when you're part of a community, it gives you a resource for strength and sharing and replenishment. But then you can bring that out, bring it to the larger community, bring it to the societies, bring it to your academic institutions, bring it to your patients. So you're kind of balancing that role between learning yourself and getting supported yourself, but then paying it forward to support and educate and offer your own improvements to the people in the communities that you serve. So I think that being part of the community and then, embracing your allies, even when the allies are imperfect at first, I think everybody has a good intention. So embracing your allies and moving forward together.
No, another great points. Thank you so much for that. Krish, you lead the last panel, my friend, for solutions.
Yes. So why don't I invite the rest of the folks on? So this last part,
let's have Natalie stay with us as well.
I'm sure if we can get the fifth camera. All right. And then we're missing
Dr.
Jason.
Pope. There's 6 cameras, I do believe. Yes. Jason, where are they? There he is.
Okay, awesome.
Hello, Jason.
Okay, so this is, I think we've heard 3 wonderful panels talk about all of the diverse issues and the kind of their own experiences and potential solutions that they've applied. This last panel is really meant for us to kind of provide some aspects of what Aspen could do in a very meaningful, tangible way that we can get accountable for in the next year, that I'm really hoping that we can present at an annual meeting and say, hey, this is what we started from this webinar, and it germinated into something really spectacular where we can actually measure that outcome in a way that we can be all proud of. So I'm going to start with Tim, and then I'm going to move to Dawood, and then Kaz and Jason, and then Natalie. At any point, you can also hold these guys accountable and suggest some ideas of ways that we can make really something that it's very actionable and something we can take away from all this wonderful experience.
So mine is very brief, Krish, because I've talked enough tonight. Mine is that we are going to establish some scholarships to come to our annual meeting, whether it be in September as scheduled or if we delay it a few months because of COVID. We're going to sponsor some scholarships for some either medical students or residents, and they can apply who have an interest in pain and neuroscience to come to our meeting. So I'm going to call, we're a nonprofit society. I'm going to call for a drive to raise $10,000 from our members, their tax deductible charitable donations, to create a charitable scholarship for 2 to 3 medical students or residents who have an interest in pain medicine and neuroscience to come to our annual meeting that will cover their airfare and their attendance. So that's one actionable item we can have, and we'll create a diverse selection committee to award those scholarships so that it's looked at very carefully and objectively to find the best people to create future leadership. So that's solution number 1 that I'm proposing. You'll be getting some emails asking you to consider a donation to this tax deductible cause of a diversity scholarship.
Dawood?
Well, Tim just stole my announcement, but I have another one too. I think that's a really a wonderful initiative, and I think we all need to kind of put our money where our mouth is and kind of donate to those causes. We're all kind of blessed financially on this panel, and people probably tuning in. So I think another thing that we really can do, this was something that we announced last year, was the creation of our diversity and inclusion committee. And I think that we will pledge the leadership and the executive committee of ASPN to promote that committee to be more robust. Whatever that's a committee that's chaired by Jackie Weisbon, who was on earlier. But whatever resources they need from ASPN to really kind of ramp that committee up, whether it's funding for travel and meetings, so they can meet in person, whatever initiatives that they think. I think that's really a high priority budgetary thing that we can focus Aspen funds towards. So that'd be one of my kind of pledges as president of Aspen.
Kaz?
Sure. Thank you so much for the opportunity to be a part of this panel. So I wanted to start with just a very quick story about when I first moved to the United States and I started school in Dallas. This kid on my very first day at school came up to me and got into a fight with me, and he started to use a lot of all kinds of derogatory terms. And we had a fight, very bloody fight, and it ended. We went to the principal's office, and the principal forced us to sit down and talk to each other. Over the next few days, we communicated. We started to understand the issues between us, and we became friends, and we were friends all through high school. The same situation happened to me at Texas A&M when I had a lab partner who refused to work with me. And when we were forced to work together, the communication and understanding started to flow, and we were friends all through undergrad and medical school as well. So I think that this committee that we have is a very, very important one. But I think that this committee needs to sit down and address important but difficult issues. So as members of Aspen, we need to bring the problems to the committee, even if they're personal problems, for us to be able to communicate, understand each other, and build on that as a foundation for better communication towards everybody within Aspen. And we hope to be able to actually make that an infectious process all through the pain management community.
I'll just make one point before Jason. I think given all the things that were said today, I realized that there's a lot of power in everyday decisions that can be different with a greater awareness of the things that these different panels have told us, right? Whether it is in picking being more mindful of the panels that we're choosing, or even just the folks that we're looking in my lab that are female, that are outstanding, giving them the same opportunity. I think I really think it's very important to take some of these things in a very distillable way that you can actually apply in your practice and kind of reflect that as almost of a practice which you preach kind of thing. So that would be my thing. That's a very practical solution that we can all apply. And I think Jason, your thoughts on what you think?
Absolutely. I certainly have enjoyed the conversation thus far, and I commend Aspen for their work and how active they've been throughout these trying times that we faced here in the United States, from COVID through the social injustices and bringing all these things to the forefront. So I want to commend Tim and Dawood for their leadership in bringing this together. And I think that as we've been in the space, and I've looked back since the time I've done my fellowship, and I've almost been in the space for a decade. I've seen a lot of different things, and I've seen perceptions that permeate the space surrounding age discrimination with access to medical care, gender differences that we think we may notice in our neuromodulation studies, race differences and how they're getting treated. And Lawrence Perret's done a tremendous amount of work looking at that, and gives a wonderful lecture describing that we treat people differently by the way they look and the gender that they are. And we are an advertised space being evidence-based. And we all say that we're evidence-based physicians, and we pride ourselves on selecting the right patients for the right therapies for the right reasons. And we cannot do that without big data to help describe and point to and identify these challenges. And so one of the things I think Aspen can spearhead is to pool our resources and our interests and our investment in the pursuit of data to answer these questions definitively, so we can come up with meaningful solutions. So it's not just something that's coming from the hip, but it's something that we have actual meaningful data to help shape a space to remove the biases that are currently present.
Natalie, any thoughts?
Sorry about that.
That's all right.
I think awareness is really important. And, we know from the literature that physicians have bias at the same frequency as the general population. And we also know from the literature that most physicians are unaware. Implicit bias is largely unconscious. So you know, while we are educated and evidence-based, I think there is a huge blind spot with having evidence as to our own biases. So, you know, I would like everybody to be encouraged to take an online implicit bias test. It's very easy, from Harvard University, and it can make you aware of some of your own implicit biases to allow you to focus on bringing that to the table. Again, I think most physicians, if not all, are very benevolent, feel a call to service, and truly want to serve their patient populations to make lives better. But you can't see your own blind spot. So being aware of that and being willing to take a look into a place that is uncomfortable is something that I would encourage everybody in pain medicine and just medicine at large to be willing to do.
You know, now they have taken that test. It's very interesting. So I think that's a great recommendation. Chris, I want to compliment you and Kaz and Natalie for the comments you brought out tonight. And I want to really acknowledge three things before we close. And that is, Dawood, thanks for your leadership. You know, you and I created the Society for Unity, and you're a good example of that. You know, you've surrounded yourself with good people, but you're very inclusive. Jason, your idea is wonderful. I think we need to really follow outcomes of our patients and find those biases, and we can't do it without big data. So what you said may be one of the most important things in the field, not in this webinar, but in the field. So as thousands of people watch this webinar on YouTube over the next few months, because we're going to market this to them so they know it exists. I think your point may be the last point of the night almost, but maybe the most important in a lot of ways, because it could change the field. And then lastly, Erica Peterson has a poster to podium program that we're also going to use as a solution where people submit posters, get accepted to the annual meeting, and then we mentor those people to the podium. And I think that can be very inclusive of a lot of people. So just some final, maybe comprehensive comments on solutions. So with that, Krish, back to you for final thoughts.
Yeah, I mean, I think that pretty much summarizes a lot of wonderful. I want to really thank all the panel members today, taking their time, sharing all of their wonderful experiences. Tim and Natalie, it's always a pleasure. You guys do an amazing job moderating. I always wonder how Tim finds so much time. He's got one personal story with every panel member that we ever bring up. So it's impressive. So obviously, we're going to have a bunch of more webinars coming up. The think tank, I know Tim mentioned at the beginning, we're trying to make some of this as a virtual think tank. So more information of that will be coming forward in the next 2-3 weeks. And hopefully, you know, I think most of us, all the faculty here, share the same sentiments that for the people that are out there listening, we are there for you. It's not just one time. You can always text us. We would love to interact, and we'd love to build your story, your career. And I think everyone shares in that passion. So I'll leave with that. Tim and Natalie, anything else you guys want to add?
Natalie, you get the final thought of the night.
Well, I'll take this thought to share my sincere appreciation for ASPN as a society. As an individual who met everybody within the last 1 to 2 years, the amount of sponsorship, mentorship, invitation has just been incredible. And I think it's appropriate that this society has taken on these difficult subjects, because this is what ASPN is about. It's not only inviting people to the table, but making sure they feel like they own a seat at the table. And I think that's a very important distinction. And I just want to credit the leadership and everybody involved with ASPN. I know that society-wide there have been great efforts for diversity and inclusion, and I have felt that personally in a very strong way. So thank you.
Great. Good night, everyone. God bless.
Good night.